introduce today's presenters. Meena Denduluri is an adult psychiatrist and was a clinical assistant professor in the Stanford Department of Psychiatry and Behavioral Sciences for the last 2 years. Prior experience includes facilitation of interpersonal and skills-based groups, teaching and designing a group therapy didactic curriculum, as well as experiential T-group course for psychiatry residents and professional support group facilitation. Laura Kasper is a private practice clinician in San Francisco and an adjunct clinical assistant professor in the Stanford Department of Psychiatry and Behavioral Sciences. Laura has led workshops for AGPA, the Northern California Group Psychotherapy Society, and the Colorado Group Psychotherapy Society. Laura is currently training to facilitate groups in Stanford Business School's Interpersonal Dynamics course. I do want to give a little overview of how Zoom will be working for this webinar. So all participants are muted upon entry. Attendees can mute and unmute yourselves during discussion by clicking the mute button at the lower left of your screen. I may be authoritative and mute you if I hear sort of background noise during the presentation. The webinar is being recorded so that everybody has informed consent, and you will be notified by email once the recording is available for viewing. That typically happens about 2 to 3 business days following this event. The chat function will be available during this webinar. So I actually do want to ask you, Meena and Laura, how you would like people to use the chat in terms of questions and answers.
Yeah, so we're going to keep the chat open the whole time, and people can feel free to pop in their questions throughout the presentation. And we'll also have dedicated Q&A time at the end. So if you want to save your questions for the end, that's also perfectly fine.
Okay. When we do get to the Q&A portion at the end, please use your raise hand feature to ask a question by clicking the reaction button in the Zoom menu bar at the bottom of your screen. During the Zoom meeting, you are able to switch between the speaker view and the gallery view. So, however, I guess I want to say I would recommend you keep it in gallery view because that will keep the focus on the PowerPoint. And then once we get to the Q&A, perhaps go to, Meena, I'm guessing you're going to take down the PowerPoint during the Q&A?
That's right.
And so, yeah, just maybe you could keep it in gallery view during the PowerPoint. And then if you wish, you can switch between, it's your option. The speaker view lets you only see the person speaking, whereas gallery view would have us all sort of together, all seeing everyone at the same time. Okay. Okay. Closed captioning is available in Zoom, which I will turn on. I'm sorry, I haven't turned it on yet. And so you can see at the bottom when I turn it on, live transcript. And you can also hide that if you don't want to see that, if that's something that is distracting to you.
And I actually turned it on just a couple minutes. Okay. Yeah.
Oh, thank you.
Yeah.
All right. So there it is. All right. Are there any questions just about sort of the Zoom functionality to make sure you feel like you can participate effectively before we begin? Okay. Well, with that, I'd like to hand this over to Meena and Laura to get us started.
Thank you so much, Kat. So my name is Laura Kasper. I'm a psychologist in private practice in San Francisco, an adjunct faculty in Stanford Medical School, which is where Meena and I did this work together. I have been a group lover since graduate school 22 years ago. This work integrates my training as a modern group analyst with the Center for Group Studies in New York, as well as the training that I've done at the Stanford Business School in their interpersonal dynamics T-group program. Before I went into private practice, I worked in college counseling, training psychologists and training. And so I was really familiar with like the challenges of getting trainees to be able to have an effective interpersonal here and now kind of training group experience. So when Meena came up with this idea to do it, I was really excited and knew that I was excited for her, but then I was excited for the possibility of anyone else running training programs. So, and I think the thing I really want to communicate here, I was a doula. So this was Meena's baby. this is Meena's baby. She hatched it. She came up with all the ideas. She drove this forward. And I think a part of why I'm saying that is I want Meena to get the credit for what the baby she created here that you're about to hear about, but also because I think it's an important element to doing a training program like this in, for trainees. If you've got a really motivated trainee, this is what can happen. So I just kind of want to say that, and I'll turn it over to Meena now.
Thanks, Laura. Hi, everyone. My name is Meena, and everything we'll be talking about today, like Laura said, was based off of work that we did together when I was a resident and then subsequently a faculty member for the last couple of years. I'm no longer a faculty member there as of this month, just because I moved to Chicago, but I'm hoping that what we talk about today will foster some discussion, and we can think about some ideas together about how to bring interpersonal groups to more training programs. And then I just wanted to reiterate that we'll be inviting everyone to keep their videos on at the end for the Q&A section. It's more of a discussion. We'd love to see you and hear from you at that point if you feel comfortable. And another reminder, this is recorded. So again, if you feel comfortable being recorded too. All right. Laura, you're on mute.
Sorry, this is high level agenda. So we're going to talk a little bit about the theoretical background and what went into this, the nuts and bolts of kind of setting it up and how it works, and some of the facilitation elements that we included. And then we'll talk about sort of post group and some of the DEI and training issues. And then there'll be time for Q&A.
Great. And one thing I also wanted to make clear, in case it's not from the title of our talk, is that we'll be talking about conducting interpersonal group with patients or clients and having trainees be facilitators of that group, and not actually running an interpersonal group made up of all trainee participants. All right. So a little bit more about the creation story of our group, which is called the Interpersonal Growth Group, and also some background about what the theoretical ideas are that have gone into to form these groups. So I'll start with my own story about how I got interested in groups, because my ultimate goal is to get lots of more trainees interested in groups and joining AGPA and doing group work out there. I had never seen a group really until my intern year of psychiatry residency. But until then, I had spent a lot of time on the wards, talking with my patients one-on-one, spending sometimes hours with them, right, in these kind of siloed interactions where it was just me and them. And I thought I had a pretty good understanding of what they were like, what kind of capacities they had, what kind of struggles they had. And then one day I went to a group because one of the psychologists who worked there invited me to come see what it was like. And I was just absolutely blown away by what I saw. I mean, these same patients who I'd work with every single day were displaying all sorts of new facets of themselves, really wonderful parts of themselves that it was impossible for me to really bring that out in them or see that in them in these one-on-one interactions where I at that point, I really wasn't aware of the power dynamics and all of that at play. But ever since then, I've been a total group person, and the magic of groups has really never stopped captivating me since then. And we had a few opportunities to lead groups. There were skills-based groups at the VA that were kind of one-off groups. There were some groups on the inpatient wards that I could be a part of. And then we also had some support groups for medical students that psychiatry residents could facilitate. But that was really the extent of my group experience. And I had some wonderful mentors who got me to the AGPA Connect meeting. I, had some of the experiential group experiences there. I started to learn a little bit more about process groups. And I just thought, this is a huge, amazing training experience that was missing that I didn't really have access to. I had tried to get in touch with people in the community who were running long-term interpersonal groups, but understandably, they weren't really up for having a trainee who would come just for a little bit and, sit in on their groups and then leave. So really the only option was to make our own groups. And another challenge is that in a lot of academic institutions like Stanford, but I think very common to a lot of places, is that the places where people have trainees are also places that take lots of different insurances, and they're subject to the same kind of pressures of managed care that any other big organization would be. And so that for that reason too, having long-term interpersonal or process groups wasn't really feasible. And I found that the people who really had depth of experience in running these types of groups weren't on core faculty at these institutions, probably because they couldn't do the kind of work that they want to in these kind of places. And so one of my mentors introduced me to Martyn Whittingham, who created something called focus brief group therapy. And the thing I love about this model that made it really, made it possible for us to do these kind of groups in our clinic systems with the constraints we had, is that it's a short-term interpersonal process group model. And I will talk a little bit more in detail about that in a little bit. And Laura is going to tell us a little bit about modern analytic groups and the T groups.
Sure. Right. So one of the key aspects of modern analytic group work is that we study resistances to emotional communication. I think a lot of times in the group world, we talk about process group, we talk about here and now. Modern analysis, it calls it emotional communication. So we study like what gets in the way of having emotional communication here in the room with the other group members and the leader. And we're trying to study sort of what their emotional training has been that hinders from that. And one of the key elements of that in modern analysis in groups is the contract. And so we set up a contract and we study how people break the contract to understand what some of their resistances are to emotional communication. And I'll talk about that in the next slide. And then the other aspect that we brought in that is part of focus brief group therapy as well, Martyn's model, is in the Stanford Business School T groups, they're also a short-term model. They're the quarter system, 10 weeks long, and they do a lot of reflection exercises. So we brought in some of that element. If you've ever done training at the Center for Group Studies, there's a reflection element there as well. So we just kind of tried to bring in different aspects to make this work.
Right.
And forgive me, I'm at the end of a flu, so I might hack a little bit. So the idea behind the contract, a group contract in modern analysis, is in our relationships, there are these implicit agreements that we make about how we're going to behave and the things that foster closeness and bring people closer together and create stability in relationships. And the contract kind of makes those things explicit so that when people break them, as they inevitably do, we study it. We study sort of what's happening. And one of the elements in modern analysis is, we have a talking group. We put things into words, not actions. You'll see that on the contract. And yet, people come late, people leave early, people stay quiet, people talk a lot. Like all those things can be kind of looked at as actions instead of putting feelings into words. So the contract's really an opportunity to have people study what feelings might be getting communicated by a particular action when they break the contract, which inevitably happens. And we want them to happen because what we're there to do is study their resistances to emotional communication.
All right. So I'm going to go into a little bit more detail about which elements of focus brief group psychotherapy we used in our groups. And an overarching thing I'm trying to convey here too is that I didn't do, just FBGT. I didn't do just modern analytic groups. I didn't do just T groups, and I couldn't because I wasn't, formally trained in any of these things, right? I was relying on Laura, my supervisor's expertise in T groups and modern analytic groups. And then I learned about FBGT from attending AGPA workshops, reading some papers, and speaking to Martyn, who's really generous with his time. And so just to give a little encouragement to people who are trying to adapt other models to their own programs, it felt okay to not be doing something 100% by the book, just according to one model, and really adapt it to our clinic system and the people who are trying to run these groups. So FBGT is a model, it's a time-limited model of an interpersonal process group that uses here and now facilitation. And this was really the thing that I was looking for, right? Because all the other skills-based groups that I could have been getting training in didn't really emphasize the here and now facilitation. And that was something I was really craving. It makes use of some really extensive individualized screening and a really extensive intake process. And that includes using the IIP 32 or the Inventory of Interpersonal Problems. And this is a questionnaire that assesses people's level of distress across different interpersonal domains. So it gives us a specific focus for that person's distress. And there's a very transparent sharing of the assessment results, which I really liked too. It was, this is this questionnaire. Hey, look, these are these results that came up. Why don't we discuss together about what this could mean, about how this could relate to what's making you seek group therapy right now? Examine the social context, what could be the drivers of this distress, and whether it's something that we could really help you address in our group. And the part that really made the short-term interpersonal group possible is that there was this rapid movement to insight within that intake process. So it differed from the long-term modern analytic type groups that Laura runs, in that you're not starting and kind of getting a sense of what interpersonal challenges come up over those first months. It's really, that piece really happens before the group even begins, and people really hit the ground running once session one starts. And within that intake process too, there's a really wonderful technique that Martyn uses called inoculation, where again, we're using these IIP results, looking at people's areas of distress in a relationship and talking transparently about, okay, how is this going to show up in the group? How might this sabotage your own drive toward making progress in the group? How can we mitigate that from happening? If it does come up, how are we going to make you be able to stay in this group and really get the most out of it? And it feels very collaborative, which I also really like. And then something that's different from most interpersonal process groups is that within that intake process, you also set behavioral goals with folks. So these are goals that they can act out in the here and now that center around their relationship issues. And you actually have a little note card. The person brings it with them to every single group. They read it out loud at the start of every single group. And after that, it's more like a process group. There's no structure, no direction from the leader about what to talk about or anything. But use of note cards and kind of keeping people on task, so to speak, that way was really unique here. And then we also do debriefing. So after the group is over, we have them take the IIP 32 again, compare their results from before the group to after, discuss with them their own perception of how it was to be in the group, what they saw their own growth as being during the group, how that contrasts or is similar to our assessment. And then we got a chance to talk about any further referrals after that. So these are all the elements that we used from FBGT in our interpersonal growth group.
So I'm just going to talk a little bit about the evidence base here. So we made a soup where we put all these different things together, and there's a lot of evidence for all the elements of it. So, we know in short-term dynamic groups that group cohesion is a really important factor in positive outcome. And one of the pieces of data about how to have group cohesion in a short-term context is having a closed group, right? Like not having an open group where people are coming in and out. So that this model has that element. We know that across therapeutic modalities, the alliance is probably the most important thing that drives positive outcome. And, some of the elements that generated a strong therapeutic alliance in such a short time are what, a piece of what Meena is talking about with the pre-group intakes, right? Like that extensive intake, she actually had a chance to develop a relationship. We know alliance is about bond, goals, and tasks. And so, in those pre-group sessions where they're looking at the IIP results, they're coming up with goals, that's really getting aligned about the task and the goal. So it kind of supercharges alliance building, I think. And we also know there's a lot of evidence for when there's focusing in a short-term model, you get better results. So yay. In terms of interpersonal therapy evidence, early positive feedback we know is really helpful. Again, it's alliance building. It's also intuitive. We all know kind of doing that early to have people feel safe and comfortable, and then start more of the corrective feedback kind of mid to late way through. And that was some of what Meena did in the model, focusing on specific observable behaviors. So, helping people actually learn how to give feedback to each other, in a constructive way. When you do this, I feel this. That's definitely an element in the Stanford program as well. Client readiness. So, one of the things that Meena really focused on and Martyn's model focuses on is what are people ready for? What's a in the Stanford, in the business school program, we'd call it like a 15% stretch. What's a stretch goal? But it's a stretch, but it's comfortable enough that you're going to be able to do it. So that it's also evidence for effectiveness. And then leader modeling, having a leader give some feedback as well, is also helpful. We know is helpful, and the evidence in interpersonal model. And the last part, we know about corrective emotional experiences, and there's evidence that having people's negative beliefs about themselves be activated in the group setting and then have it disconfirmed with feedback from other people. It's what helps change happen. So this model has lots of evidence base behind it. So next, we're going to talk about the nuts and bolts of the group.
All right. And before I go to this, I forgot I was going to mention that Martyn has a whole webinar about FBGT that he did over the last few months. So there should be a recording of that too, in case anybody's interested. There's a lot more detail in there about how those groups work.
Oh, and Meena, actually, and relatedly, Martyn is running a training at AGPA this year on this. So you could do the webinar, or you could go to AGPA and participate.
Thanks. All right. So just a few nuts and bolts so that, hopefully it helps convey just very concretely what was involved in starting these groups. I think it's helpful to have trainees very involved in advertising a new group if you're starting it, because if you are, whether you're on faculty there or a volunteer faculty, the trainee really may have even more institutional knowledge about all the different clinics, all the different people in different parts of the organization. So they can be really key in helping advertising. So we, created a blurb, advertised in every clinic, many in person, emails, flyers. We advertise it as a trans diagnostic group with a primary area of concern being relationships. And then in later iterations of the group, we really emphasize that we discuss culture, social context, aspects of identity, and how they may impact people's interpersonal challenges as well. And that actually helped recruit a much more diverse crew of participants in the group as well. I think people who were the referrers had it a little more on their radar that we may be addressing some of these issues, and that I think that was helpful for folks. We had to do multiple rounds of advertising in the beginning, and in later iterations, the referrals came in a little more easily throughout the year. And then in terms of inclusion and exclusion criteria, we mentioned that we're looking for patients who are able to tolerate some feedback, who are not having a lot of active suicidality, active mania, active psychosis, or active substance use challenges that would make it hard for them to engage in the group. There were not any kind of hard and fast exclusion criteria. It's not that we wouldn't interview anybody, but these were some of the criteria we put out there. And it was not, I think importantly, it was not a requirement that they also have an individual therapist, because I think that really would have impacted access to this group. And since it is a short-term group, it made it less feasible. All right, so I've mentioned this extensive pre-group preparation, and I'll go into a little more detail about that now. So this pre-group preparation, again, comes a lot from Martyn's model. We start out with a one-on-one interview. I would generally do this for 60 minutes and then have 1 to 2 follow-up visits for 30 minutes. And I would have loved to just do 90-minute visits, but we found that patients' insurance covered at most that first 60-minute visit and then additional 30, but not the full 90. We did a really focused interview about whatever interpersonal challenges they were facing. We talked about the reasons they may have developed these challenges, and also really what is it about their various contexts that might bring about these challenges, right? Is it really something about particular environments you're in that is making this a challenge for you? Is it something that's consistent for you across different contexts? Could it really have more to do with people outside of you, around you, than you, right? In that case, would this really be something helpful to work on in here if it's not really something that you have much control over? How are different aspects of your identity related to your interpersonal challenges, right? What aspects of your identity may be marginalized, may be oppressed, may be privileged? Which aspects might show up in the group? Which aspects come up in your workplace, in your family? How are family of origin dynamics related? All of this would come up within the first 60 minutes. And the way that happens is, again, because that IIP 32 really helps us just cut right to whatever the one main specific focus area would be. And the way the IIP 32 works, it's I think fairly easy to score, but it gives you a percentile, and it tells you among 8 different domains, interpersonal domains. Some of them are, being domineering, being self-centered, being unassertive, socially inhibited, etc. Martyn uses some more patient-centered language to identify these 8 different domains, which we also adopted. So, for example, rather than overly accommodating, we called that focused on on the needs of others more than your own. Instead of self-centered, it was easily able to focus on your own needs rather than others. So it gives you a little cutoff score. A certain number percentile is above clinical significance, another percentile is above average, and then below that is really, pretty run-of-the-mill for everyone. And so we would pick the ones that were the highest or just above that clinical significance and start there. Sometimes we would stick with that area when it came to making their goals, which I'll talk about in a sec. And other times we would end up with something different because it turned out that the IIP result really wasn't related to their primary area of distress overall. Okay, and then again, the main idea with the pre-group prep is that we're catalyzing the insight piece before the group even begins, rather than the group slowly generating insight over the course of months or weeks. And then in that initial 60-minute intake, after that, we would meet 1 to 2 more times for a half hour to refine their SMART goals. And I will talk about that now. Okay, so this is the piece, right? Making behavioral goals so that they can be working on that pretty explicitly. That's different than a lot of other interpersonal group models. So once we've identified a specific area of distress, we make a SMART goal. And SMART stands for specific, something very specific, something measurable. So meaning we can track it during the course of the group, something achievable, right? Not something way too hard that is going to set them up for failure, not something too easy where they're not going to experience any growth, something relevant R to their area of distress. And then T is time limited, which of course happened because our group was time limited. And we would very collaboratively make a SMART goal with the patient, with your client, something that they really want to be working on. And then we really help them make it so that it's a goal that can be acted out in these groups. And one key thing we talked about was that the goal should be just 20% outside your comfort zone, right? So something that is not super easy for you, but not something where we're going to be setting you up for failure and making you, throwing up from anxiety before the group starts every time. We don't want that either. And I'll give you an example about how somebody might come up with an interpersonal goal that they could enact in real time. So let's say that on the IIP 32, they have a really high score on being overly accommodating, or rather focusing on the needs of other people instead of their own, right? This shows up in every context in their lives. It's something that's caused them a lot of resentment. They are suffering from health issues because they've been doing this, and they want to change that. Seems like a pretty big ask for a very time-limited group. But the way we might make that into a goal is, okay, what if you were the first person to start the group? Once we go through and, you read everybody's goals on the note cards after that, what if you were the first person to say, hey, I have something I'd like to talk about in the group, just twice over the 12 weeks that we run this group? And then we might talk about, okay, how scary does that feel, right? Does that feel way out there? Should we cut it down a little bit? Or does that feel too easy? And, we should make it 3 times in the group. But that would be a way that they would have to go out of their usual mode of operating, take a little risk in this hopefully safer, psychologically safer environment of the group. And then they could ultimately take that growth with them once the group is over. We talked with folks about the group as being a social laboratory, right? A place where they could try on behaviors that are slightly different from how they normally are, and see what happens. All right, and now Laura's going to talk a little more about the different profiles that can come up, and then some more example goals.
Yeah, so what we wanted to show was just kind of how the IIP can come up with some typical profiles and some typical goals for people. What's so great, I think Meena talked about this, but the 2 dimensions on the IIP are, there's sort of an affiliative dimension, which is kind of how warm or cold, somebody sort of runs. And the other one is sort of agency, which, is kind of the dominant submissive one, which Martyn, and Meena as well, like we didn't use that language, you use sort of more of a assertive, unassertive. So these 2 dimensions, we all know working with interpersonal issues are primary. And so it's a really helpful kind of way to profile people. So, the top one, the withdrawer, a withdrawer or an unassertive one, an example of a SMART goal with somebody like that might be, share 3 personal details over the course of 12 weeks. Then there's the oversharer, someone who's really warm, but pretty uninhibited. I think in Martyn's model, the oversharer, and as well as is the sort of self-involved type, this is an example, I think, of kind of an inoculation. So somebody who we know can, if they're oversharing a lot or they're taking a lot of space, it can cause some damage in the group sometimes. And so, there's a conversation about that, the goal isn't that we're asking them to give up this part of themselves that shares or takes space or whatever, but it's more that we want them, to be successful in the group. And so we're wanting them to try on something a little different, so for the oversharer, it might be, to tune into and match the amount of sharing of kind of the middle person in the group, with a self-disclosure by, the 3rd session. The next profile, the pleaser, so the pleaser is focused on the needs of others and is really sacrificing. And this was the example that Meena just gave, maybe the challenge might be to be the first person to ask for time, 1 or 2 times. So then the self-involved person or someone who's a little bit more domineering, again, this would be kind of an inoculation, reassuring them that we're not trying to take away their ability to, get their needs met or anything, but just to encourage them to try something different. So it might be, asking a follow-up question of another group member, so sort of doing something that reflects paying attention to other people. And this example, 6 times in 12 weeks, maybe that's too much, maybe it's 3 times, but the yes person, the person who's assertive, but focused on the needs of others, actually maybe encouraging them to ask for help from the group, as opposed to always being the one to help the other people. And then the complainer, who might be comfortable talking about their complaints, and instead of complaining, the goal might be, when you feel that urge, because they're sort of in tune with their complaints, to maybe pause and instead try to name a feeling one time each group. So these are just some examples of kind of how the SMART goals fit with some of the profiles that come out of the IIP, which is really useful.
Right.
Okay, next, we're going to talk about some of the facilitation elements.
All right, so this is some more nuts and bolts, a little concretely about how we run our groups. So when we first started the groups, this was pre-pandemic, we did 90-minute groups every week, and it was ran for 12 sessions. But once we moved online, we did 75-minute sessions, and based on scheduling, we did either 10 or 12 sessions. The ideal size for groups is about 7 to 8 patients, particularly for online groups. For in-person groups, they could be a little bigger, especially if we have the full 90 minutes, but really 7 to 8 turned out to be the sweet spot. And another difference from other interpersonal groups is that in session 1, there is a fair amount of structure. So we would start with introductions. We would talk about how the umbrella goal, right, thing that everybody is ideally moving towards, in addition to just working on your individual goal, is to feel like you can form some healthy relationships with some degree of closeness in here in the group. And that would really help to get people invested in each other, not just overly focused on meeting their goal that's on their note card. We did icebreakers, which again is different. We might start initially with leader introductions, talking a little bit about who we were, parts of our identities that we wanted to share with the group, invite participants to introduce themselves and briefly in whatever way that they wanted as well. And then moved into some lighter icebreak activities, something like, what's your favorite smell? Asking everybody to go around and say that to get people out of the super cognitive mode a little bit more into physical realm. And then we would do breakout groups when the group was online. So we'd pair people off in dyads and ask them to find one thing that they had in common. In Martyn's model, he actually has people go around with a paper and pen and do sort of like a more structured activity, but I found challenges with doing that online. So we just asked people to find something that you have one thing that you have in common with somebody else in your dyad. And then we would talk a little bit more about norms for the subsequent groups. We would say, this group in the final session will be fairly structured, but in between, every group will start just with you reading out loud your goals. And then really the floor is anybody's who'd like to begin. And it will be my job and my co-facilitator's job to make sure we start and end on time. And then we would also do a reflection exercise for the last 5 minutes of every group. And then another thing we did in that first group was in the large group, everybody together, we asked folks to talk about what would make you feel most welcome in the group and to build on or respond to something that's already been said before them to get them again warmed up to this mode of engaging with one another directly, speaking to one another directly, and taking in what somebody else is saying and responding to that. In the first session, we also did a very brief contract review. In some other interpersonal group models, they spend a lot of time talking about the contract in the beginning, and that's how we started with our model as well. But given the short-term time frame, it ended up being that it was easiest just to go over it briefly to make sure we're all on the same page, but not have that be as much of a focus. And then, so sessions 2 through 12, like I mentioned, start with just reading the goals. And then from there, it would be a regular here and now group, with the addition of me making sure that whenever a person meets their goals, I'm keeping track myself on a piece of paper and encouraging real-time reinforcement. Because when people take that risk in the short-term model, if they don't get feedback right away for that risk that they've taken, we don't have the luxury of time, right, to kind of help them move through that self-consciousness, that any regret they might have about that vulnerability. So it's really important right away to reinforce it. And that might look like in the form of asking folks to reflect for themselves what that was like because we noticed that they met their goal, and also inviting feedback from other group members. We also did midpoint leader feedback. And so this would look like the group before the halfway point. Myself, my co-leader would give folks a heads up. Hey, next time we're going to be asking for your feedback for us. So we want to hear, how are we doing as leaders? How is this group going for you so far? And finally, we did a more structured termination session where I would assign a little homework before the last session, ask folks to write just one sentence about the way each other group member has impacted them, and to share that with the group next time they come. And we went around and did that for each member. And that turned out to be a very meaningful experience for everybody. In terms of the reflection exercise, so this I initially had people do in their own time after the group was over. I would send it to them over our EMR system, have them send it back to me. All that turned out to just be a little bit too much work for everybody. And I didn't get a great return rate. So I started including it right at the last 5 minutes of the group. And we just invited them to write a little reflection for themselves for 5 minutes. They didn't have to send it to me, but if they wanted to, they could. And some of the questions we asked there were, what was one thing you noticed about yourself in the group but did not speak about today? What was one thing you noticed about someone else but did not speak about? Which group members had the greatest impact on you today and why? What aspect of your or someone else's social identity or culture influenced your participation today? And what was one feeling you had toward a group leader today? And to consider bringing up one of those things in the next group.
So now we're going to talk about kind of what happened after, and then some of the DEI and training issues.
Okay. So one thing I'll say is I just had so much fun doing these groups. It was fun before. The intakes were awesome. It was a totally different experience I had compared to my other training experiences in residency. It wasn't everything, right? It wasn't your medical history and your family history and your all your medications and everything. It was just this thing that you would like help with. How did this happen? How can we help you with this? That was awesome. And so in the post group follow-up, I asked folks to fill out the IIP 32 again, and then we would talk about with them, okay, let's take a look at your scores. How did this change? And most patients' distress really decreased around their targeted interpersonal domain, which also just made that so fun. It was so rewarding to see that. I also got some written open-ended feedback, and people said, I didn't realize that there were other people going through this kind of thing. It was so validating to hear from other people who had similar struggles. It was amazing that the same kind of challenges that come up for me in some other areas did show up in the group, and that I could actually work on it in here. I really thought that it was, I didn't know how I could work on this in this kind of group therapy thing, and it got them more interested in doing other longer term groups after our group. And then the way I concretely did the follow-up was that we would schedule a 30-minute video or phone follow-up. And then I'd also talk with them about where else they could continue the kind of work that they had already gotten started. Because this was a short-term group, because we didn't require that they also had an individual therapist, this turned out to be a place where people jump-started some of their growth and a lot of them were very interested in going on and continuing with the one-on-one or a long-term group in the community, which was awesome. And the other thing that helped to get this feedback, to have some hard data, was that it helped give a rationale to our clinic and our supervisors to be able to continue this group, which was really key. Okay, so aspects around diversity, equity, and inclusion were increasingly central to our group, both in pre-group prep, both in supervision, as well as group facilitation and afterwards and recruitment. Here are just a couple of the ways that that came about. And this is definitely an area of ongoing growth for us, for me, for Laura, and for the group. So in the pre-group prep, one of the really nice things I loved about Martyn's model too is that it really puts social context, culture, identity front and center in this discussion of, what are these interpersonal challenges that are coming up. We welcomed and found ways to facilitate discussion of issues related to race, religion, gender, class, et cetera, as they were showing up in the group. This is still something that I'm working on, but that between the first and the final groups, I can already see how much more these discussions entered our groups just because of my own increased training. And again, hopefully a lot more of that will come up as time goes on. Laura and I also reflected a lot about how these issues were coming up in our own supervision between me and Laura and how we were thinking about our group. And then we also discussed an informed consent with our group members. So if we're talking about the group as a social microcosm, right, we also had to bring up, this is a group. I don't have 100% control over what other people may express in the group. And so the types of forces that are present in terms of, bias, et cetera, that are present in the outside world may show up in our group too. Is that part of the risk that it would be okay for you if you're participating in this group? And of course, I would say, I will do as whatever I can as a group facilitator to notice that, to talk about it, to mitigate it as it's coming up. If somebody is not appropriate for a group, I wouldn't include them for a group, et cetera. And yet these risks still exist in our group. So that was another place that came in. My co-facilitator and I also, over the course of the group from the first time we did it to the last time we did it, did a little more self-disclosure, particularly in that first session. And we found that also helped people have these types of conversations and that they weren't coming up in earlier groups and all of a sudden they were in later groups. And we had quite a bit of influence over that. And then people also sometimes made SMART goals around asserting certain aspects of their identities. So they may, for example, an example would be, I identify as non-binary. I've recently started identifying this way within my social circles, and I would like some more practice doing this in a group of people who I don't know. Could we make a SMART goal around this? And we would go through all the pros and cons of doing that, figure out a way for them to do that in a psychologically safe space. So another way that comes in is through the goals. Okay. All right. In terms of training elements, so I started these.
Oh no.
Oh no. Did Meena just drop? Is that
Yeah.
maybe what happened?
Oh.
Uh-huh.
Nope, she's back.
There she is.
Hey.
You're
Here we
muted.
go. Let me make you co-host again. All right.
Thank you.
There we go. You're only gone for a second.
A little surprise.
Okay. All right. Can you see this now?
It's
It's
starting.
not back yet.
It's
I
not.
think.
It's, yeah, there we go. There we go.
Okay. Okay. So when I started these groups with Laura, I was a fourth year psychiatry resident, and it was perfect timing that Laura came on as our adjunct faculty member around that time. I found a really wonderful core faculty member at Stanford who was willing to be my co-facilitator for these groups. Even though he didn't have a ton of experience in prior groups, he was willing to kind of learn with me, and Laura supervised both of us. So initially I was doing all of the intakes and doing the group and getting supervision with Laura. And then once I was a faculty member, we turned it into a 6-month rotation. So 3 months, the trainee would do intakes, first would watch me and then would do the intakes themselves, and then facilitating the group for 3 months with ongoing supervision during those full 6 months. And then supervision with Laura and me for the full 6 months. We also opened the rotation to other trainees as well. It turned out that it wasn't just psychiatry residents who didn't have this type of opportunity, running an interpersonal process group. It was PsyD students, it was psychology students. So we had other people come on as well. That was awesome. And every single time we had a resident or PsyD student or a trainee come on, the group would evolve, right? They would give us ideas about how this group could be better, ways of facilitating. They would challenge me to consider, reflect for myself at parts of my own style of facilitating. And every time it just evolved, which was also made it really fun. It was really important for us to have a supervisor who had really solid group training, which, it's hard. It was hard in my experience to come by a lot of people like that. And then somebody who also not just had extensive group training, but was getting ongoing training around DEI issues in group and supervision. That also, I think that combo is really hard to come by, but Laura really fit that bill, and I was really grateful to have her as a supervisor. We had my program director created a lot of flexibility in our schedules where we could do what we wanted with our time, right? So during my second year of residency, we had 2 months of something called scholarly concentration time, and I used at least one of those months to just explore an interest in group therapy, which was the start of really these groups, the idea for these groups. And then a lot of flexibility in the third and fourth year where I had time to do all this recruitment, to do all these intakes and all of that without having it be part of a pre-existing clinic. There was program interest, right? So I mentioned Laura came in at just the right time, but that's also because our program director had interest in getting somebody with psychotherapy and group psychotherapy expertise, which also I definitely didn't take for granted. You need to have trainees with some interest in group therapy, and I think that interest can only come up with having a variety of experiences here and there. We as trainees, we had our own process group, and that also spurred a lot of interest in this for me. But not every program has these. In fact, it's a minority of residency programs that have process groups. And then financial support and other types of support for attending the AGPA Connect meeting for me as a trainee was also really instrumental. I never would have, gotten to go to Martyn's workshops, gotten to learn about all these different types of groups that were out there. Our groups wouldn't have happened, and this rotation wouldn't exist for future trainees. So that was also really wonderful. I, as a faculty member, I did not have protected time for taking on trainees who were not psychiatry residents, which was a barrier. I kind of donated my time for this and because I loved it a lot, but for the long term, I don't think that would be sustainable. And that's something that, would have been great to have. And so this is basically how we made this model into ultimately a rotation that's an elective that's available for our residents. But I, during the Q&A, we'll take questions from other folks who are here, but we'd also love to hear from any of you about your experiences running an interpersonal group that has trainees and how that's worked, what kind of challenges have come up and how you've overcome those, and a few other things too that Laura and I would like to ask you all. Laura, anything else you want to add before we go to our Q&A?
Yeah. Go back to the previous slide. There was one thought I was having. No, sorry. The one you were on the train. Yeah. Mm-hmm. One thing, point number 3 was consider other measurement-based care. One aspect of Martyn's model is, he does the IIP to get what the interpersonal difficulties are. And he also does an outcome measure. And, you know, you can do whatever outcome measure if, you know, you're going to use this model. And part of my understanding of that is in the discussion about the goals, he uses the outcome measure also as motivating, like to tie, like how much of these interpersonal difficulties are showing up for you in, you know, in this life functioning challenge you're having. So that was just a part of his model I think is important and is part of like the motivation. Yeah.
Perfect, thanks.
Mm-hmm.
And actually, before we go to Q&A, I'm just going to do my thank yous now in case we don't get time for that later. There were so many people who helped us make these groups happen. Peter Van Russell was the attending who was willing to co-lead with me. Martyn Whittingham, of course. Liz Kortenkamp was our clinic coordinator. She sent out all the questionnaires and, you know, scheduled our patients, ran their insurances, and just couldn't have done that without her. Sepida Bajistan, Sally DeGolia were our faculty members who were very supportive. Craig Forte, Judy Simon were group therapy experts who opened up my world of group first. And Judy encouraged me to come to AGPA. She said it a bunch of times before I finally did. I'm so grateful. Dr. Yalam was one of my supervisors during my concentration time. He was the one who introduced me to Martyn Whittingham, and I was so grateful for his time and expertise as well. Jackie Wang and other residents who have been with us. And then the U is really just, you know, everybody who I've gotten to meet at AGPA Connect, people who are running workshops, people who I've just had the chance to be in with in large groups and small groups and all that. Just every single person continues to make me appreciate the magic of groups and want to keep coming back to Connect and train other trainees on groups, because it's just so awesome. And I want everybody to have the opportunity to do more of this stuff. All right, so I'm going to stop my screen share now so that we're going to invite people who feel comfortable, you know, keeping their videos on or turning them on and joining us in the Q&A. Okay. I guess first, Laura, we can invite questions from the group about what we've presented so far, and then we can save at least 15 minutes, hopefully, for an overall discussion. Does that sound good?
That sounds great.
Okay. All right. So we'd love to hear what questions or comments you have about today's presentation.
I'll jump in. I have lots of, can you hear me?
Mm-hmm.
I have a lot of questions, but I'll just share one for now. Can you say more about the reflection questions? I really love those and then took note. I'm not sure if you saw the question in the chat box to see if we're gonna get copies of the presentation or not, because I was quickly jotting them down because they were so significant to me. I didn't know if those were things you adapted, and I believe you mentioned them in reference to maybe Modern Analytic or or CPGS uses them, and just wanted to have a little bit more understanding of the context.
Yeah, absolutely. We can definitely make a copy of the presentation available later. We can ask our liaison to help us figure out how to send it out to everyone. So the questions, yes, some of them came from the Center for Group Studies. They use some of these questions in their training groups for therapists. And I will actually just copy paste the questions in the chat in just a minute. And then a couple other questions we added. So one of the questions was around what aspects of your social identity or culture, other people's social identity or culture impacted your participation today. That was to get people explicitly thinking about that and reflecting on that. Many people who started our groups had no idea what we meant by that question. They're like, what do you mean? And so we would explain, does the fact that does other people's age impact how you participate, right? Does the gender of somebody who you're interacting with impact your participation when depending on who's giving you feedback about this thing? How are you relating to the other Asian women in this group compared to other groups? There's maybe something different about that based on what you're saying today or something like that. We would do a lot of that in the pre-group prep also to get people get that part of their minds exercising, and then in the group as well. And I'll put those in the chat now. But thanks for your question.
Looks like Rita has her hand up. Oh, you're muted, Rita. You're still muted.
Just unmute me. Okay.
There we go.
Thanks, Kat. Mine's more of a comment than a question. I went to Martyn's workshop twice at AGPA, and I, like you all, I was really intrigued by it. I thought it offered a lot of structure to short-term groups because I used to work in college counseling. But I wasn't as lucky as you all in terms of I did not find support from it among my peers. They thought that it was too much work, too many interviews. So I still adapted a bunch of it for the groups that I ran, and I found it very helpful. The one thing that I thought was the most difficult for me was using the IIP. Part of what Martyn talked about was trying to match people so you don't have all people who are in one place, like all people who are, focused on others, but we never had enough people to put in groups to make those kind of choices. And I don't know if you all ran into that, but I guess it sounds like that you were very lucky to have the support that you did, that it's really hard to pull this kind of thing off unless your peers, or supervisor, whoever has the power to make it happen, gives support. And it's fabulous that you ended up making a rotation out of it.
Yeah, Rita, that's the bummer that you didn't have more support around it. And I would say we didn't do that either. We did not create groups that were perfectly balanced because, like you, we just didn't have a ginormous pool of people that wanted to or itching to do our group. So I just didn't do that. And that was the one way we didn't strictly follow his model. We kind of made do with our situation, and it still luckily worked out. And not everything was perfect. Of course, that's why the group keeps changing every single time we run it. And I will say I was the only person doing all the intakes, and I would get people referring to me, but it was a lot of work. But because I was in this training program that let me to do what I wanted, kind of, and didn't put pressure on me for revenue and all that, I had the time and space to build this. Yeah. All right. Kat?
I always feel a little like, am I allowed to ask a question or comment? I love this presentation, and I really want to I would love to see something about this at Connect and attend it and talk more about it. I thought this was awesome, and I want to learn more. So I primarily specialize in neurodivergent, trans, and gender expansive and queer people. And I really didn't know much about these. I took a little picture to refer to it, but the types of folks and sort of their different behavioral goals. And I just wanted to make a note and as maybe a discussion topic, but there's a part, and I'm multiply neurodivergent myself, and there's a part of me that was like, whoa, this is so helpful. And then immediately was like, neurodivergent folks may experience these as rules that actually are helpful, could be helpful, right? If we have certain social goals that we have a lot of trouble understanding how to behave any differently because we don't understand the function of certain social behavior, but may have a lot of trouble applying these flexibly. And so just naming, just that I got really stimulated and curious to talk about everything that was presented specifically with neurodivergent clients. Because another thing about neurodivergent clients is that behavior isn't often communication. It's a representation of structural differences in the brain, sensory processing, you know, and executive functioning impairments. And so it was just a really, yeah, I just got very stimulated to think about this with my specific populations. And yeah, I really appreciated this. And I really want to do brief therapy work, because I also find with neurodivergent populations that I work with anyway, a sustained, like just like super long-term process group can feel like a lot to ask of a person, especially who has a lot of group-based trauma. And so I'm really very interested in brief psychotherapy. So I just want to make that comment. And again, I think it's, yeah, just very stimulating. And thank you so much. It just sounds like such good work. And I really hope you keep going with it. So thank you.
Oh, thanks, Kat. I really appreciate hearing your comment. And I actually want to make sure I understand one thing too. Are you saying that with the behavioral goals, that those can be interpreted as rules outside the group or in the group, and it's kind of a, like there'll be a penalty for not doing it or something? Would you mind elaborating on that a little more?
Sorry. Yes, I actually meant, I mean, it could be perceived that way depending on where the person's at. But if they're coming in with the goal of behavior change, which not everybody is, but if they're coming in with the goal of behavior change, I actually saw this through that lens. Like I was like, oh my gosh, be the person to speak first, right? Like as a way, you know, or too self-involved is something that neurodivergent people get a lot. And they don't mean to be, I don't mean to be, things like that. But this ask a follow-up question, that's a great rule. That's a really helpful just tool, right? And but what I mean by that is that neurotypical people may be more able to apply that flexibly, like just sort of, as opposed to neurodivergent people that I work with, and myself included, will apply it more as a fixed and rigid, okay, now I do this thing. Now I'm going to do this thing, both in the group and outside the group. And so just, yeah, again, love to talk shop about sort of how to think about the application of this with that population. Just really cool. I just think it's really fascinating.
Yeah, no, that is super helpful to think about it. That was not on my radar. And I can think of lots of ways it could potentially be helpful and not so helpful. Yeah.
I think it's really, yeah, I don't want to, you know, I don't want to take over the, yeah, but I think being aware of that is actually the most important thing. I actually, I really rely heavily on some of those rules, you know, to be, okay, just tell me how to do small talk and then I'll do it. And neurotypical people don't know that I'm doing that because I've learned how to do it. So it's actually helpful to know the rules. Just mention what weekday it is. People love to talk about what weekday it is, right? Just mention the weather. People love to talk about the weather, you know, so it's not bad. But I think just as the provider, being aware that it will be applied differently and for very different reasons can be just a helpful framework. Anyway.
Yeah, that's a really helpful insight. Thank you for sharing that, Kat. Oh, more people have their hands raised. If John, you're muted.
Hey, sorry
There
for
you
the
are.
unflattering camera angle. My 1-year-old's taking a nap where I usually have my stuff set up. So this isn't really like a well-formulated question, and so it's more of a thought, and I'm hoping that others can take it somewhere helpful. But so I just completed my first, I work at the Minneapolis VA, and I introduced this whole focus brief model, and it took way more effort than it should have to get it going. And so I think one of the challenges that I struggled with is I appreciated like the modern group analysis focus on like the contract and breaking the contract, and we're going to talk about what that means for you. But then I found a lot of times it really started to occlude the goals of the members coming into the group. It became more about like, you know, we had 12 sessions, and a couple of the sessions were spent more talking about the breaking of the contract, which did have deep meaning, but it really took away from, you know, those 2 or 3 goals that we focused on in the beginning of the group. So I think for me, as being like a more attachment oriented therapist, like modern group analysis, like really speaks to me, but then I really have a hard time keeping it to the focus brief model 12 weeks. So I try not to be too rigid. So again, like this is not a well-formulated question, but I'm curious if others who have tried this run into similar issues, and just, I'd be curious what kind of, how you think about that as you approach this. I don't know. connect.
We totally had that issue, John. Yeah. I used to spend the entire first session, maybe even plus more a second session, just talking about the group contract, getting people's reflections on it, all of that. But now it only takes up a few minutes in the first group for that very reason. I had the same challenge that it would almost felt like it was derailing it, and kind of like I wanted everybody to talk about the group contract, but they were here for something else kind of thing. And so over time, what's happened is that, we don't belabor it as much. I don't let it take over the group content, but I still make use of it. So an example would be, there might be somebody in my group who has the goal of bringing it up once in 12 sessions when they need to pull back a little bit in the group, or something feels uncomfortable to them and they need to express that. And it just so happened that the thing that happened was another group member had contacted that person on Facebook in between the groups, even though it's in our group contract to not have extra group interactions while the groups are in session. And so that person did their goal by referring to the contract and saying, we had this contract where I know we're not supposed to have outside group interactions, and it made me uncomfortable when this person did this. And then that allowed us to have a conversation about that. So, person who reached out on Facebook, as you remember, the contract is there not to be rigid rules and not to make you feel like you're going to get penalized, but it's just a point to think about, okay, what might this help me understand about my own challenges when it comes to relationship? What made me reach out, even though we had talked about this thing and before the group and in the first group that, it's not a norm, and what made you reach out anyway? And how does it feel to hear from this person that, that it made them feel uncomfortable, et cetera. So make use of it, but I kind of, I find that I have a lot of influence in how much people talk about the contract or not. I don't know if that resonates for you.
Yeah, that's really helpful to hear. Sorry, let me put my hand down. I think similarly, my issue was a member who kept showing up late, and I had individual contact with him, telling him to be on time. And then there were group members who were like, okay, I'm doing my goal today. And then he'd show up late. And I'm like, so do we just continue to not address this guy who's showing up late? But the one group member was taking a risk. He was doing exactly what he was supposed to do. So I'm like, okay, I guess we'll focus on him because he's at least adhering to the contract and doing what we came here to do. So I don't know, maybe I'm just frustrated by like the time limited nature of the system I'm in, and I don't know. That's helpful though. Thank you for that perspective.
John, I guess follow-up question for you. Was he the only person that was ever late the whole time?
No, but he was a repeat offender.
Because, I think, to obviously like working on the contract and exploring lateness, in a long-term group, like you're doing that, over time. But, a question, right? A couple sessions into people being late, just kind of the leader noticing like, hey, I'm noticing that some people have been late, right? As opposed to like targeting, right? Like scapegoating the one late person. Like, I'm noticing people are being late. I'm wondering if, people are having any feelings about that. Just the light touch, the sort of salt and pepper questions, I think can be helpful in a short-term situation.
Yeah, I agree. Thank you.
Jocelyn, did you want to respond as well?
It's a related question, but new question. I was going to ask, in what circumstances in this model did you find yourself responding to people outside of the group? In my limited early career group experience, that's something that I'm struggling to navigate. I've done different training experiences, and I'm just curious, based on what you've presented today, were there circumstances where you found yourself meeting one-on-one outside of the kind of outline you've shared?
Yeah, good question. So some of the patients in our groups were people I was seeing individually for medications or something else. And so with those people, I did have contacts outside, but if there was group content that came up, I would kind of gently say, that's a great question, a great reflection. Why don't we bring that up with the group, or why don't we see what the group has to say about that and redirect that way. Initially, if someone didn't come to group and we hadn't heard from them, I would reach out to them individually over a message. But in later groups, I used Laura's idea to actually call the person while the group was in session and let them know in the pre-group prep and in the first group that we would be doing that. If we hadn't heard from somebody and they weren't there, we will call you because, the whole group is going to be thinking about you and hoping you're okay, kind of thing. Yeah, that was a little new thing for me for sure, but I actually found it felt nicer once we started doing it. Yeah, I'll stop there.
Thank you.
Yeah.
I was just going to respond the lateness thing and the group and the contracts. This the one thought I was having was you also mentioned you're at the VA in that position, right, John? I just had one thought. I know I'm not doing case conceptualization, but because I work with neurodivergent people, right? It's like chronic lateness and missing appointments is sort of a thing, right? And so I do a both and approach with that, which is that I think disabled and marginalized people are often the people that may represent some of the resistances. That's one of the ways I look at it. And so I think that's one way to do the both and approach and bring in the identity pieces. So like in a VA situation, there may be neurodivergence, but there could be, the PTSD pieces or other aspects of disability that the group is even using that person to break contract, right? Or to make an expression, and then doing the individual piece around is how is this showing up in your life and how can we get you more individual support? Because it can be disastrous, right? If it has other impacts, functional impacts. So I do both and it really helps people not get scapegoated while also kind of looking at all of it at one time. So just I would mention that part.
Thanks, Kat. All right, so you can feel free to continue bringing up questions about the presentation, but I'm going to pop in the chat a question that we have for all of you.
Yeah. And one thing I guess I wanted to, I saw Fahad's question about dealing with resistance in time-limited group therapy. Yeah, so one modern analytic technique for that is joining. So I'm just thinking of an example of how you might do that around goals, right? So people in these groups are identifying these goals of, what they're going to do different, but the whole point is that they have resistance to doing those things, right? And so, a way of joining might be, you know what, Sally, you don't need to do your goal. You don't need to do that goal until you're good and ready. Like, it's fine. You don't have to do that thing, say that thing, not say that thing. Just don't do that until you're good and ready. That's like a modern analytic kind of joining the resistance. And so the idea is that if you make it okay, it's kind of like you make it okay. And as the leader, you're kind of owning the position of like, you don't have to do anything you don't want to do. Sometimes it can free up the resistance in the person where they're like, oh, okay, it's okay that I'm exactly how I am. And then, it might be part of resolving the resistance. So I just wanted to address that question. I don't know, Fahad, if that's helpful or if you had something,
Yeah, one other thing I was going to say is that resistance, quote unquote, can be talked about in the pre-group prep, right? When you're collaboratively creating the SMART goal, it's totally driven by what that person wants to be working on. They decide how hard or easy the goal is going to be. They make the goal. They bring it in on a note card every time. And then also in the group, we check in and say, around the midpoint, how are folks doing with their goals? Are there ways that we could all be helping you meet your goal in here? Help you meet that goal by the end of our group. We have 6 more sessions left. And also bringing up at the start of every session, we have 10 sessions left, 9 sessions left, 8 sessions left, to create that time limited pressure a little bit for people. So both of those things combined, I think, can help too. And Fahad, was there something you wanted to add about that as well?
Sometimes the group therapy is provided in a setting that maybe a psychiatric patient or in a school short-term group therapy, but the participant or the group members attend the group without having a goal or without, just it's in the site, they participate and they do the they attend the group, but not participating in like sharing or doing activities or not drawing, because in our therapy groups they don't do the activities, but just attending the group and not doing anything.
Yeah, I mean, for some people, sometimes, Fahad, that's as much as they can do. I mean, I guess you're sort of maybe speaking a little to the quiet member, and joining the quiet member in it being okay that they don't have to talk until they're ready. That's a way of joining that kind of resistance and potentially making it okay to eventually speak. But if they know that the leader is sort of protecting them, they're not going to get attacked for being quiet. That sometimes that can help resolve that resistance. I don't know if that's helpful, but.
Yes, thank you.
All right, so I'm going to ask the group a question. I'd love anybody's reflections on this. Laura and I are curious, what has been your experience with training trainees to run interpersonally oriented groups, and what has worked? What are some of the challenges that have come up? And I posted this in the chat as well. So yeah, we'd love to hear about some of your experiences.
I can share since I just wrapped up with my pre-doc intern. So I think like a lot of VAs, like they tend to draw well, at least in the Midwest, they draw like very behavioral folks. So her doing this group with me was really anxiety provoking. It like really, I think she came in thinking that like the behavioral goals would mean that like the group was very structured. And so I think it was a really good skill set for her to learn that like you can conceptualize from a behavioral standpoint, but treat and your interventions can be more dynamic and attachment. So I think it was really helpful for her to like learn how to like think on her feet and provide more person-centered feedback in the moment rather than simply cognitive advice or behavioral goals. So I think it really helped her grow. And I'm hoping that our intern training program adopts this model a little bit. I love how it became kind of like, it sounds like a rotation with you guys. I think that's great.
You're muted, Meena.
Thanks. John, do your trainees have to rotate with you, or is it an elective?
It's an elective.
Okay.
Yeah.
Cool. Kat asked a great question. Laura, I will defer to you and start getting us started on this one if you're up for it. Can you define interpersonal versus here and now and psychodynamic per se?
Yeah, I mean, I think we use these terms interchangeably, Kat. I don't think there's a distinction at all. I think here and now, psychodynamic, interpersonal, I think they're all connected. I mean, maybe the psychodynamic piece. Oh, go ahead.
No, that's all I needed to know. I was like, I don't know. I've trained a lot of people in the latter. Okay.
Yeah, I mean, I think the psychodynamic part, at least in, my groups and my work, is that means that when people are stirred up emotionally in the group, that I'm asking them and interested in, how is this old or familiar? What's getting replayed for you in the dynamic with this person or in this context? So that for me would be the psychodynamic, the history.
Mhm. And probably in more strictly psychodynamic groups, there's more of thinking about there and then stuff or historical contributions, and maybe going into that, delving into that a little more, versus maybe more strictly here and now. You're doing a lot less of that. But the people who have been interacting with, who do a lot of group therapy, do some kind of combo, like Laura was saying.
Then I can answer the question. I just was, I'm like, I want to be good. I want to, I want to answer the wrong question. In general, I haven't worked with students in quite a long time, but I've trained a lot of people in treatment settings, and postdocs and things like that. And I think in general, my experience is similar to John's, that, but there's a craving to want to do the here and now work. And so often what I find is people want, I guess my general comment will just be that people want to be in their own therapy in order to become more comfortable, to be truly present in the here and now. That's what I've noticed the most, is that, whoa, this is stirring up so much in me in the room. I need to do some more personal work, and that comes up in supervision too, when I'm training on this stuff, that it's like, no, we're not going to be doing a skills intervention. Like, we're going to be doing a really emotional intervention and asking and being with, and you're probably going to get really stirred up as a therapist.
Mhm.
And so that's been, I guess, my main comment is that's what I notice in doing group training specifically. But I did a lot of this on the West Coast, and I will say that on the West Coast, people are like hungry to do that, so even though they get really stirred up and anxious, I notice that people are like, that's what I want to do.
Yeah, I think it's really difficult to do this work unless you're in your own, you've got your own places, whether it's your individual, therapist. I mean, I'm in training groups, right, with seasoned group therapists, to get that support. And because, we're the instrument. We're the instrument. We have to take care of the instrument.
Yeah.
Yeah.
Rita, go ahead.
I was just going to add, I sort of like John, I mean, I'm in Pittsburgh, but it's essentially the Midwest. And I worked with a PsyD program that was very behavioral. And so I would say maybe 1 out of every 5 or 6 PsyD students really loved group and wanted to do it and enjoyed the interpersonal and went on to either go to AGPA or CGS. But I would say the rest of them, like, it was scary. It was way more, the here and now was frightening, kind of what Kat was talking about. Their program did not encourage doing your own therapy. So it's just an uphill battle. I was talking about my own department, the counseling center, but the PsyD program as well, like, never hired somebody to teach groups.
Yeah.
So you really need all these supports to have an ongoing program. But you still get these individual trainees who, get the bug and go on, and that's exciting.
It's true. I mean, I do think, Meena, she highlighted Sally DeGolia and Sepida Bajastan, and they were instrumental they both love group, see the value of group. And then when Meena came and was like, I want to do this, Sepida, like, she went out, she was like, I'm going to find somebody that can then make this happen. Yeah.
And we are at the end of our time, sadly, but I just want to put in a plug for a couple of things. One is the group training and supervision SIG. I'm one of the co-chairs for that SIG. I love having these conversations. I would encourage anyone who hasn't already to join that SIG and come talk with all of us more. I moved to Chicago, so if anybody is doing Chicago training, therapy, etc., please email me, and otherwise too, just to continue this conversation. I'm so thankful for all of you coming here today on a Sunday and using your free time to talk with us, think with us. Super grateful. So thank you all so much.
Yeah, thank you for all your contributions and participation. It was really a delight.
I
Oh,
do have
Kat.
to say, we have concluding comments. Sorry, just about the recording and your CEs. So just let me find my little closing comments document. I've been taking notes. Okay, here it is. Okay. So please make sure to complete the evaluation survey and your CE test if you purchased your CE. So when you close the Zoom window, you should still actually be in the e-learning classroom window that you entered through. So then you'd click the I have completed this requirement and you'll be taken to the survey and test. Registrants can re-enter the classroom up to 30 days after the webinar by logging into the AGPA member homepage, clicking on e-learning. If an extension is needed after 30 days, you would email Holly Lundgren. And I'm going to put her email in the chat for anybody who needs it. The webinar will be available in 2 to 3 business days. Holly will send an email notification along with instructions once it has been posted in the e-learning classroom. So here's Holly's email address. Okay, thank you all so much. And thank you so much to Laura and Meena. This was wonderful.